Beautiful slides. This is the OBGYN part of the lecture. So this is just giving you a clue of how you do the 2D, 3D, and a 4D. But what I want to really show you is the vascular ultrasounds. So this is the two books I would like to recommend for you to review. And again, the reason why you want to learn ultrasound, because if you know the first time we used sonar or radar, we really didn't believe all those clouds. They were the Japanese aircraft, and we thought, oh, there's just some rain coming. So this is why it's better to learn how the ultrasound works. And what you need to remember, okay, that's a different mouse. Hold on. So this is what you need to remember. Wow. Okay. So this is the frequency what we hear, and everything above, that's your diagnostic ultrasound. And I'm going to show you how it really works, how we are changing the electrical power and making those sound by the ultrasound. If you're a musician, this is the beautiful frequencies of your piano keys. You need to have a double piano to really have about 2 megahertz. So this is your hearing test. We are starting with 2 kilohertz. Do you hear it? Good, because if you have a hearing loss, that's the first sign of syphilis. So make sure you hear this part. So the other part is we are reaching about 20. Do you hear this? Good. You're not a dolphin or a bat. So that covers it. So this is the two ways of how we generating our ultrasound. And basically we are shooting, and this is how you have the black and white scale, grayscale image about every fifth going to generate a color for you. We have some new technology going to do an ultra fast image like that. So when you hear the machine called supersonics, this is how they're generating the images. You already heard you don't want to hold your probe with 90 degrees because the cosinus 90 is your 0. For some reason, we came up with this idea to standardize the velocity measurement to cosinus 60. Everybody argues maybe cosinus 55 would be better. We don't care, but all the standards going for cosinus 60, and it's really simple, just 0.5 times of your normal velocity measurement. Everybody knows about this, how you hear something coming towards you, has a little bit of higher pitch going away, it's just a lower pitch, and this is how the Doppler effect works. And again, just practice on your own hand, but the main idea, what you want to see in every ultrasound machine first, your color scale. The color scale tells you red coming towards you, blue is going away. That is the first thing of your reference. Then, depending on which direction you're pointing the ultrasound probe, you can generate a signal coming towards you or going away in that vessel. So here's my really easy, simple example, and that's one slide you need to remember. Okay, the one slide you really want to remember, that here's your red coming towards you, and we are changing the box angle. That box angle helps you to reference and make sure you don't keep it straight. So the common carotid coming from deep to the surface, that's what's directing your angle. So this is why you don't put in a reverse angle. So the ICA is going from the right side of the screen to the deep. You have the other angle. So what you noticed, that we did change the color box. So coming towards you, red, going away is red. So that's all the time your reference. What you see the color box, that's your favorite reference. And just last week, 10 years experience sonographer called a reverse vertebral. No. So she just totally missed the color box and how your color box is referenced to that. So this is your normal high resistance waveform, what you see all the peripheral vessels. On the carotid, you see internal carotid, a low resistance pattern. Renal artery, gastric after you ate, coronaries, those are the low resistance bed. They're gonna suck all the blood. So this is why the brain gets 25% of the cardiac output, because the low resistance bed sucking in diastole. Why the leg is not getting too much? because in diastole, you don't have too much flow down the leg. So that's the high resistance patterns your normal waveform. In a moment, you see the stenotic, increased velocity, or you see something in diastole, that's not good. And finally, when you have this monophasic post-stenotic waveform, that's the sign that you have a significant disease proximal to that waveform. Why? Remember that beautiful first slide I had, the mountains. In the moment your systolic upstroke disappears, you have a significant disease between your heart and your measurement point. So first your systole, delay, and becomes kind of blunted and disappears. These are all the post-stenotic waveforms. So this is tricky. Numbers are low, but the waveform tells you there's a disease there. So this is why you really need to learn how to look at those waveforms, and sometimes those numbers on the report just don't make sense. The other beauty, what you need to understand in a single waveform, that again, you have your systolic upstroke, there's a notch, and there's a nice long diastole. So this is your aortic valve closure. What is this notch? We have another aortic valve? No. So remember how the artery have that muscular elastic layer? So carotid going to dilate a little bit and give you another push. This is how the pulsation works. So that is the beautiful pulsation, tells you there's no hypertension. And this is a really nice hemodynamic feature of the vessel wall. It's not rigid, it's still pumping. In the moment you have chronic hypertension and your vessel wall is diseased, this is where this is going to be a cap, and no longer you see this notch. So pay attention to those tiny details on those waveforms. Extremely high resistance, and when it's extremely low resistance, those are your AVMs. And again, you're going to see it in the created AVF as well. So here's one more time, your systole, diastole. Kind of funny how we have just a short systole. And these are the extra waveforms, what you need to be aware of. Next door, they're probably going to talk about the intra-aortic balloon waveform more than we do. But this is the intra-aortic balloon waveform generating an extra beat. And if you don't time it too well, that can even steal. So the delayed deflation of the balloon, so as you see, one is assisted, not assisted, not assisted. So this is 1, 2, 3. So when you do 1-to-1, each of the waveforms are assisted, and this is what you don't want to see in the internal carotid, because it means that in diastole you're going to start steal waveforms. Hemodynamics, real simple. Double velocity, 50%. Triple velocity, or 4 times, is 70%. So on your paper you see some wiggle room for you. So, but over 3 times, we're just going to call the 70-75% stenosis. One thing you need to see this is the Spencer-Reid curve. When we talk about hemodynamic significant disease, and this is what the hemodynamic significance means at 70%, that your flow volume no longer can be coming through the same area. So when the velocity going up, right around 300, you're going to drop the flow volume because you cannot deliver the same amount of flow through the same stenosed area. So what happens that in this is the flow volume starts to drop. But it's really funny. If you have 300, you can have a 70% or a 95% stenosis. The two clue is if behind the stenosis, how much your velocity drops. 300s drop to 30, that's your 95%. 300s drops to 100, that's your 70%. Cool? Spencer-Reid curve, that's what we call something hemodynamically significant, that's 70%, not because someone just wanted to do stenting at 70%. Waveforms. This is my favorite waveform, and I want to teach you what is the subclavian. We're going to skip the brain dead. You don't want to see too many of those. And this is the occlusion. The vertebral just bouncing to the, hitting the wall, diding. That's your bouncing to and fro waveform. And we call the alternating waveform for the subclavian steal. So what the subclavian steal waveform going to give you, I'm not going to talk about the disease too much, but you have your pressure difference between the two arms. This is a normal waveform. This is a total reversed high resistance waveform because you're not feeding the brain with a vertebral anymore. You're going to feed the arm. That's why it becomes a high resistance when the vertebral reversing, most often with an occluded subclavian. But between, there's a bunch of different waveform changes what you're going to see. And these waveform changes, sometimes you just get a V-shaped cutout in systole, alternating, and this is when it's kind of reversed. This is why it's really good to see the vertebral waveform anytime you don't feel the pulse and you have issues with the subclavian waveforms. Confirmation test, put the blood pressure cuff on and monitor the vertebral. If you see the waveform changing, that's a positive hyperemia test to confirm the subclavian disease. So vertebral, it's a good reference that you see the vein going to a different direction, but always remember your, again, color. And the color box is always going to kind of help you to really see that when you see two blue, that's going to be your reversed artery. But here you have another reference that you look at the vertebral direction and you get the carotid direction. Both of them going to the same direction. That's another help for you to decide if you can figure out the direction of the vertebral. So here's when it's alternating. And alternating is red, blue, red, blue, red, blue. So that's the red, blue, red, blue. Whoever likes Barcelona as a soccer team, that's your red, blue, red, blue, red, blue. I so like that computer, whatever you guys are playing with, but these slides are getting somewhere. I'm going to show you something pretty cool. My friend Roger and Tyree made this beautiful video. And this beautiful video, I'm going to skip these carotid images because we're running out of time. This is just showing some thyroid disease. We like to mention that. This is cool, guys. I've never seen anything like this. It's finished yesterday. This is how fresh. I volunteered and get me some sound, guys. This is Esther, my lead tech, and showing you how to do the protocol of the carotid step by step. So we're going to put it on a YouTube soon.
We start in a transverse
and the whole idea is that you see how your hand needs to be quiet and steady.
Live segment and
so she's doing the cross section, same time you see what your ultrasound kind of see.
Back.
This is cool. Seriously, I haven't seen anything like this. That you show again what your left hand doing while you're doing your ultrasound, and at the same time these are synchronized throughout. So thank you guys. This is really beautiful. I just don't have time to go through the whole things, but you're gonna able to see this 5 minutes. This is how long does it take to get these one side of the carotid done. I don't think I'm gonna have too much time for the venous disease. I want to show you one really fast. Learn about the subclavian. When you have a good AVF and you need to have a low resistance subclavian disturb waveform in the subclavian, that's always going to help you. Hey, that AVF is working. In the moment you have high resistance subclavian, that AVF doesn't work. So I think that's the waveform of the subclavian going to help you again to see all disease. And again, half of our studies are carotid, another half is low extremity venous. So indeed, we need to do the compression. So that's one of the first parts what we do that makes sure that the veins are, again, compressible. And this is where kind of confirming throughout the whole leg with the cross-section and also the longitudinal view of the probe. And we are also augmenting distal and we are augmenting proximally. So this is how you really want to see the protocols. This will be the next video we're going to generate, and for you will see that. So I'm gonna do the next one. And again, we talked about the arterial ABIs. So on my paper, the ABI is 0.9 and 8, 0.95, but definitely less than 1. So we brought the ABI down to really pick up all the normal values, but again, the waveforms. So when you see these waveforms, pay attention to those, and I think the waveform going to really pick up where the problem with the disease. Remember the color signal and how the power Doppler going to help you with the near occlusions because the power is not sensitive to the velocities. And we have some new toys called the B-flow on the GE. Looks like a contrast. It's not. Looks like a contrast given for really near occlusion and some ulcerated plaques. You can see really beautiful images. The other new technique, what we're trying to use is this is where they call elastography, so how the ultrasound is propagates, and the ultrasound propagating and find a solid nodule, have like other reflections. And guess what? What we want to see is that when you see an acute occlusion and you want to see the age of the clot, it's going to help us to see the elastography, how soft, how hard it is. And this is my second example, that this is a CEA suture line, and you see why the endothelial hypertrophy happens there, because this is the high pressure region. Kind of cool. So I'm running out of time. I just want to say with my last slide is, if you don't want to learn ultrasound, Dr. Lumsden came up with a new idea, teleproctoring. So with a remote visitor one, we can guide you if you're stuck, and in the operating room we can monitor the cases. And but I would encourage you to learn a little bit more ultrasound. That's my email on my last slide. Can advance, so, but you'll find me in the program, and I'm here to chat if you are interested to learn more ultrasound. Thank you, guys.
Thank you.